angiography guided PCA. So basically, they showing as a intravascular imaging guide is superior in the terms of complex lesion. Previously, the study, ultimate trial and so much study was held based on this simple lesion. They don't include the complex lesion. And many of these study, mainly in China, Korea, they shown that major adverse cardiovascular event was significantly decreased. But non-study justified that cardiac death. But this study different from previously study based on the cardiac death. Because I mean to say that this study showing after the 3 years of follow-up and large population size, they show
does major adverse cardiovascular events include cardiac death or it does not include?
Yes, sir. Major adverse cardiovascular death leading to cardiac death. So basically they show primary endpoint and secondary endpoint. So I am going through this study. This is New England Journal of Medicine showing that intravascular imaging guided or angiography guided complex PCI. What the study is going to show is background is that complex coronary artery lesions are associated with worse clinical outcome. As you all know, the simple type A lesion is a better outcome as compared to type C lesion, complex lesion in the sense of a bifurcation lesion, left main ostium lesion, or heavily calcified lesion, more than 2 or 3 vessels disease, or any plaque burden is high. So they involve mainly the complex lesion in this study. So having this point of view, complex lesion having a low outcome, but the study showing all the participation as per the inclusion criteria are complex lesion. So previously trial had CTO IVUS, AVO, bomb days IVUS XPL and ultimate. So with the reference of this study, they conduct this 3 years of study from May 2018 to May 2021. Compare IVUS versus angiography guided PCA show better outcome with IVUS. However, limitation when limited sample size, short follow-up duration, or inclusion or highly selected lesion subset. This is mainly saying for this previously study. Previously study does not showing any cardiac death related outcome in the sense that there are limited sample size. The sample size is so much low and the follow-up is at least 1 year or does not follow more than that, and inclusion of the selected criteria. So this whole study, this is the better than. So I just go through this previously study. Like 2025 American Heart Association published CTO study. So mainly they showing that intravascular IVUS, they only OCT they do not include in this study. The IVUS mainly they showing clinical impact of IVUS guided CTO. The study is a CTO IVUS, so mainly participant was CTO, and with a drug eluting stent, jotarelimab versus biolimus eluting stent implantation. This is a randomized open study. So clinical impact of intravascular USG guided chronic CTO intervention with jotarelimab eluting versus biolimus eluting randomized study. So what they include, they all the CTO cases with IVUS guided and using the new generation, second generation drug jotarelimab, and showing that this is a multi-centric randomized study, a better outcome with IVUS as angiography versus the IVUS. So they showing this number of 402 patient, half patient divided in the angiography group and half patient divided into IVUS guided. So ultimately the composite of cardiac death, M and target vessel related after the 12 years follow-up, they showing that significantly decrease in the IVUS guided. So this showing IVUS guided CTO intervention did not significantly reduce cardiac mortality in the same, but this randomized study demonstrated that IVUS guided CTO is improved 12 years of major cardiac vascular event. Again, this is the AVO trial, also a prospective type of randomized study, and they mainly IVUS, the benefit of IVUS using the stent optimization and stent apposition in compared with the angiographically. So they are showing the benefit of IVUS with implantation of drug-eluting stent in complex lesion in post-procedure because when we using intravascular imaging, we doing the approximation and pre and post intravascular stent apposition and stent diameter edge dissection and all this. So it is a better outcome. No statistically significant was found in after the 2 years of follow-up adverse cardiovascular event. And again, this was the Homdays IVUS study. These are the published in 2009, long back, 7 August. So in this study, they studied the invasive coronary treatment using drug-eluting stent with or without IVUS guided. So this is the randomized study, and they showing that if the angiographically you are doing putting stent and then maximally post dilate, and with the compare with the IVUS guided, there is no any difference statistically significant on measured cardiovascular event or any mortality benefit, but this showing that better outcome, better result, and with this they showing the dual antiplatelet therapy, and they showing the follow-up with IVUS regarding the stent thrombosis or restenosis. Another IVUS.
How long was the follow-up in this trial? Long term like it?
Almost 5% of 50% mortality, high risk clinical stage.
Follow-up कितना months के year?
They are showing the 3 months, 6 months, 1 year and 2 year. So the effect of another study, IVUS XPL randomized trial, intravascular USG guided drug-eluting stent implantation. On this study, basically on station on China and Korea. So these are another study who showing that the beneficial of intravascular IVUS in the follow-up patient in the we are putting this drug-eluting stent. So this compared with the angiographically stent implantation versus the IVUS guided stent implantation, result significantly low cardiovascular event as compared with the angiography. So they following this 5 years of clinical benefit result from the 1 year to the 5 year of stent implantation in the sense of restenosis, stent thrombosis, or any stent dissection or whatsoever. And these are the 3 years another trial, ultimate trial. Based on the ultimate trial, we are going to discuss to Renovate. So the ultimate trial, they are showing, they are held in China, and the aim of the study is to, after the 3 years of target vessel failure and intravascular USG guided versus angiographically guided in the second generation drug-eluting stent. So these are the randomized multicentric trial having showing the lesion with follow-up 1 year and target vessel failure after IVUS guided compared with the angiographically guided. So at 3 years, they include 148 and IVUS guided versus angiographic guided. So after the 3 years, they defined, including the safety profile, they demonstrate that the significantly lower rate of target vessel failure and stent thrombosis in the 3 years follow. So again, this ADAPT study was showing that there is event-free survival with IVUS guided, and against this Illumine 3 optimized PCR trial based on they include the OCT in this trial. So patient who undergoing OCT or guided PCR in complex cases like left main or heavily calcified 3 vessel disease, long lesion more than 80 or heavily calcified. So they show statistically significant clinical outcome as compared with the angiographically result. And these are opinion trial. So they showing that the intravascular IVUS and compared with the OCT versus IVUS plus angiography. So now we are currently using the second generation drug-eluting stent, and this opinion study showing that these have the significantly at least the post dilatation we are doing with this intravascular imaging is better outcome with this study. And this rope cohort 2 study published on 2021 showing that superiority of this OCT and IVAS they are basically focused on left main stenting. So they're showing the superiority of compared with the angiography guided study. So these are the which are showing the added days, IVO trial, Omnes IVAS, Reset, Sequo IVAS, and IVAS XPL and Ultimate study. So all of this study showing that if we compare between imaging guided versus angiography guided, so major adverse cardiovascular event is higher in angiography guided. As we can see, the risk reduction relative, we are showing the data that here majority of study have low sample size, but in ADAPT study and IVAS XPL Ultimate they include more than 1,000 patients. And the follow-up is 1 year or hardly 2 years. But we are going to discuss Renovate trial. They include 1,639 patients with mean follow-up 2.1 year, and they follow 3 years study. So they having demonstrated that it is superior than. What are the objective of this study? Intravascular imaging guided PCI using IVAS on OCT would improve clinical outcome as compared with the angiographically guided PCI patient with complex lesion. So how we can define the complex lesion? We can these 9 criteria like through bifurcation. We can use Medina classification for that bifurcation with the side branch at least 2.5 millimeter or more than. CTO with more than 3 months of occlusion, and unprotected left main disease, heavily disease, and length of stent is 30, lesion of stent is more than 38 multi-vessel, like more than 2 vessel involvement, with stent needed at least 3 on one sitting, 3 or more stent needed, and having in-stent restenosis or stent thrombosis, and severely calcified lesion. We can see on angiographically the calcium burden or CT coronary angiography, posterior lesion like the LCX, LAD or RCA. So basically the study design is Boston Scientific and Abbott Vascular, they sponsor the study and held at Samson Medical Center in Korea, and they doesn't involve in this study design or outcome, but they only sponsor. And these are the study basically include 1,620 patients who undergoing PCI in complex coronary cases. So they basically divide into 2:1 ratio. Imaging guided having 1,018 patients and angiographically 540. So 2:1 they divide, and they doesn't define any this particular group going to OCT or this group. It is based on the operator, the freedom of operator who choose the who are taking for OCT or who are taking for IVAS.
All the patients were presented as SCS?
Yes, sir.
All?
No, all the some of patient is chronic stable angina, some acute coronary syndrome, but majority more than 50% or 51% patient having ACS, and they include the diabetes, kidney failure, but they preserve ejection fraction they include in this study. No low EF or cardiogenic shock or having less life expectancy less than 1 year, it doesn't include in this study.
Any multivessel and any multiple stent is complex.
Complex as they define as
We can make simple as multiple or complex also. Like that.
they are very particular in
There are
inclusion criteria.
2 vessels and very simple, then also we can do it.
No.
Consider it as complex.
Complex having maybe ostium, bifurcation, and
Number 5, multiple vessel, PCI more than 2 vessel.
but they at least showing the heavily disease burden, calcium, and
That is not female.
Sir, more than 2 vessel in the same session means if we are doing in the different session, then it is simple.
That is what I am telling you.
Yes,
And
yes,
2
you are
vessel at a time
Yes.
means it is complex.
It is complex.
2 stent at a time means it is
It is
complex.
complex.
એટલે બે રીઝન એવા આવે કે જેમાં તમારે ખોલવું પડે એવું હોય તો એ simple ना जो it is more obvious.
Actually, here we are defining the multiple stent. Means if there is a more than one lesion, but the stent we are implanted is 3. If we are implanting only two stent, they are not including that in a complex until unless it is a bifurcation. But we are implanting 3 stent at a time, then it is a complex.
So, sir, what if a patient presenting with anterior wall MI having LED diagonal, so it is considered as an image there?
If LED diagonal bifurcation, then it is a complex case. But if there is a simple LED and simple diagonal, then it is not a complex case. If only 2 stand. So they have specific classification. True bifurcation means if we have to do crossing and kissing, means it is a we implant both in the bifurcation manner. So it is a complex. CTO is complex. Then left main is complex. Then ISR or stent length is more than 38. If we are putting a single stent which has 48 mm, then it is complex. Because any type 3 lesion is complex.
What he is asking that anterior MI with LED and diagonal both two different blocks, it would have been complex only, no?
Sir, if the total lesion means if I am putting 18 mm 2 stent, so it won't be complex.
Forget length of the stent.
But there are two very clear case, one diagonal and LED main. LED
Left main is always complex. Any left main is always complex.
LED stem માં છે અને diagonal માં છે અને anterior MI છે બંને 99-100% છે અને બંને એક bifurcation પર નથી અને બે સ્ટેન્ડ મૂકે
It is simple.
ચેક કરી દે આપણે.
Actually sir, एमा lesion lead पर है.
Cancel is single, sir.
हाँ, एमा lesion lead पर है. जो total stent length is more than 38, then it is a long segment disease, then it is complex.
ચાલો સ્ટેન્ડ લેન્થ નાના નાની છે બસ.
It is simple.
Are you sure?
हाँ.
તો આ ભાઈનો ક્રાઇટેરિયા ખોટો પડે. 5 નંબર
5 અને 6 નંબર છે ગૂગલી છે.
Sir, 6 number में more than 3 stent.
5 નંબર
5 number में more than 2 vessel. It is not 2 vessel. It is single vessel. ना SVD का है. LED territory is LED diagonal. Is SVD.
ઓકે.
LED LCX का so then it is DVD. Then 5 और play person.
મલ્ટીવેશન મીન્સ LED LCX અને
RC.
RC એ ત્રણમાંથી બે હોવી જોઈએ.
हाँ.
એની બ્રાન્ચ નહીં.
ना.
ઓકે.
So they randomize for the aim of the study is to treat the patient. Whoever participate, whoever refuse and give do not consent, they basically involved in the study to intention to treat this patient. So the randomized 2:1 for the treatment strategy of target lesion. They include stratified acute coronary syndrome and participating center. So this patient 540 is angiographically guided and 1008 is image guided. So all patients were followed after the 1 year of period. So as I mentioned, this postal scientific network vascular, they were not all in this manufacturer script writing. So what they include and exclude in participant, mainly the age more than 90 years.
is different. Go to previous slide. All patients were followed until 1 year after last patient enrollment. But at the end of study, out of these 1500-1600 patients, how many patients data actually is available? સમજો?
Who can follow up with OPD or
બધા આવેલા
they
છે
should
ડિફોલ્ટ થયા હતા કોઈ કે જેનું ફોલો અપ ના પૂરું થયું કે એવું બી હશે. હા તો એ કેટલા
they show data in next
આવશે?
slide. Yes.
ઓકે બસ.
So this inclusion showing that complex age more than 90 years with complex coronary artery lesion defined as the previously as I mentioned bifurcation branch with more than 2.5 mm with CTO and left main having long vessel. This is more than 38 with multi-vessel and multiple more than 3 stent needed with ISR and severely calcified with osteo. These are the exclusion who patient having contrast-induced nephropathy, history of any drug-induced hypersensitivity. We cannot include in this study. I mean, those patients are exclusively pregnant or breastfeeding or patients who are at shock or who are not crossing the lesion, means target vessel not amendable to PCI.
It is very disheartening. If you expect a complex lesion and you exclude the cardiogenic socket presentation, then the majority of the real world patients exclude करना.
Because this study
बराबर ना दोस्तों?
this study based on the cardiac death or because this patient might be.
તું કને તું તારો અત્યારે એન્જિયો કરે છે એમાં કોમ્પ્લેક્સ લેઝન આવે છે એમાં કાર્ડિયોજેનિક સ્ટ્રોકનું પ્રમાણ કેટલું પ્રિવેલન્સ મોર ધેન 50%. હવે એક તો પેશન્ટ તમે ઇન્ક્લુડ નથી કર્યા તમારા ટ્રાયલમાં.
But sir, the impact overall the result.
અગ્રી પણ તમારે રિયલ વર્લ્ડમાં એક્સ્ટ્રાપોલેટ કરવો પડશે ને ડેટા. તું કહેશ કે ગાઈડલાઈન ઇમ્પ્લિમેન્ટ થવાની છે કે થઈ ગઈ છે વોટેવર, બટ ઇફ there is no data on cardiogenic stroke,
This is intention to not the patient saving. This is intention to showing the intravascular having superiority.
Sir, frankly, practical purpose જોવા જઈએ ને તો if patient is in the cardiogenic shock, the main target is decrease the dye amount. અને જો OCT એક રન લઈએ ને એની અંદર 40 ml ડાય જાય. એક એન્જિયો જેટલી ડાય એક સિંગલ OCT રનમાં જતી રહે. એટલે તમે પ્રી અને પોસ્ટ કરો ને તો 100 ml ડાય તો ખાલી OCT પર જતી.
તમારે મોર્ટાલિટી બેનિફિટ પ્રૂવ કરવો હોય તો જે હાઈએસ્ટ રિસ્ક પેશન્ટ છે એમાં પ્રૂવ કરો તો કામ થશે. બરાબર, these are the high risk patient. ઠીક છે, વાંધો નહીં, તમે ટેકનિકલી સાચા હશો, બટ આનો તમે ડાયરેક્ટ એક્સ્ટ્રાપોલેટ ના કરી શકો પ્રેક્ટિસમાં કે ચાલો આ હવે આપણે કોમ્પ્લેક્સ પીસીએચ એટલે ઓસીટી સાથે કરી નાખીએ.
The RCTs are RCTs and RWD means RWD. They are entirely different.
Yes.
રિયલ વર્લ્ડ બી ડેટા આવ્યા હશે ને, એટલે આગલા ટાઈમથી આ યુએસ ફરક છે છેલ્લા 15-20 વર્ષથી તો આપણે સાંભળીએ છીએ.
No one is using in the emergency or the in the shock patient.
ખાલી પ્લાન્ટ ઓલામાં જ કરે છે.
Exactly, plant. They all are using in that, and most probably no one. There are many means in many centers they are trying to avoid to treat the patient in intervention. Means they do not do intervention in the shock.
તો શું કહેવાય?
મોટા ભાગે નથી કરતા સર. મોટા ભાગે actually outcome differ નથી કરતો. There are multiple trials.
ઇન્ડિકેશન શું છે? કાર્ડિયોજેનિક શોકમાં હોય તો પીસીઆઈ કરવાની છે.
If there is an acute anterenal MI,
હા,
single target अथवा जो primary PCI is indicated, other than primary nothing is indicated, not a second vessel PCI.
અગ્રી છે, એટલું તો કરવું પડશે ને. એટલું તો કરવું પડે.
પણ એની અંદર કોઈ આઈવોસ યુઝ જ નથી કરતું. પ્રાઇમરી ફટાફટ આઈવોસ વગર ઓપન કરીને ડૂટી ગયો.
So in Western world, at least I mean.
સો એનો મતલબ એવો થયો કે આ તો ઇન્ટિરિયર એમાં આવ્યું, LED 100% બ્લોક આવી. Unfortunately, આઇટમની RCA 100% બ્લોક હોય તો you will not touch RCA right now.
RCA એક્યુટ મોટા ભાગના કેસમાં નથી હોતી. અને
Agree.
we are not going to touch
અરે ભાઈ
RCA.
આવી ગઈ, ચાલો, પણ આવી ગઈ તો
નહીં અડવાની.
નહીં
નથી અડવાની. અહીંયા સર અહીંયા જ હમણાં 4 દિવસ પહેલાની જ વાત છે. LED 100%, LCX 100%, ખાલી RCA થી એનું સર્ક્યુલેશન થોડું ઘણું મેન્ટેન હતું. RCA was good super dominant. We have done only LED. Even LCX was done after 4 days.
so staged PCI એવું
Stage
થયું.
PCI.
પછી LCX કેટલા percent હતી?
100.
So you did FFR IOS એમાં કે કરી ખોલી જ નાખી.
Sir, there is another factor that is called financial factor.
Of course.
Market in India it is far.
એ ફેક્ટર તો આપણે જોતા જ નથી. બરાબર, વેસ્ટર્ન આપણા ઇન્ડિયન કોઈ સ્ટડી હવે છે જ નહીં. આટલા 10, 15, 20
ઇન્ડિયા રિસર્ચ સ્ટડી આવશે માર્ક સ્ટડી.
Market study also, sir.
How to improve mortality in mark patient.
So if patients are unwilling having a pregnancy allergy and target lesion not I mean PCR and patient in shock at present with life expectancy less than 1 year.
What is intolerance to aspirin, clopidogrel, prasugrel? Intolerance એટલે શું? How you define this?
Patient having intolerance sensitivity to this drug having
Sensitivity is a different story. No? Intolerance એટલે
because all these participants were given to P2Y12 and aspirin and at the follow-up they showing that stent thrombosis or they are major cardiovascular
That
event.
is different story. Intolerance is patient is not able to take the drug due to side effect, due to a severe gastritis, vomiting or allergic to aspirin.
They are
or anything related to bleeding going on એવું બી કંઈ છે? આવું intolerance નથી જોયું આપણે.
Before the study, we cannot comment on the patient having bleeding because of don't know. So if a patient having a history of allergy or maybe
And then
hypersensitivity.
so allergic and hypersensitivity mentioned. The intolerance is a different thing.
પ્રોબ્લેમ કરે એવા હોય ને પાડી દે.
Gastritis primary aspirin intolerance માં gastritis થાય છે.
એટલે આ બધા RCT બધા બહુ 5 criteria.
So, what they show in the study endpoint with the primary endpoint and secondary endpoint. So, is the primary endpoint after the 1 year, they showing the death, cardiac related death, cardiac death, target vessel MI and clinically driver tiger vessel revascularization. And what they are showing at the end of study secondary endpoint. So, they showing the target vessel failure without procedure related MI, target vessel related MI, and death from cardiac cause and having stent thrombosis. So they randomize in mainly web-based randomized study all the eligible patient having stratified with acute coronary syndrome and non-acute coronary syndrome. So they data collection based on this electrical case form report and all these angiography reports, particularly the institute level after ethical committee approval, they show by the core laboratories, and the data safety and monitoring board was given the for this monitoring, and all clinical event either it is okay. So what are the they using the Boston Scientific and Abbott Vascular stent, everolimus or drug-eluting stent, and using divers and OCT in the procedure. And they set up the protocol for selecting the reference segment for particular complex lesion for this appropriate stent size selection for where to OCT guided, where to IVUS guided, selecting the stent. And if we are using IVUS, then it should be at least less than 50% plaque burden with involve a large size of vessel. And if OCT, then is no lipid containing with normally looking like segment. So at least 5 mm apart from the target lesion covering. And about the sizing of stent, I mean they external membrane diameter of proximal and distal reference segment by they cover the proximal and difference segment with OCT guided at least up to the nearly 0.25 mm segment diameter and human diameter at distal reference segment. So length of the stent at least covered from distal to proximal as per the reference site. So what are the optimization after the procedure or stent implantation? So the expansion, apposition and dissection, they are showing this defined as they assess their angiographically diameter stenosis if residual stenosis less than 10%. Like if we are going to left main or non-left main. Left main, non-left main lesion, the minimum stent area more than 80% of the average reference lumen area, or more than 5.5 in the sense of IVUS, or more than 4.5 in OCT, and they set up. If left main is larger than the 7 mm for distal and more than 8 mm for proximal left main by intravascular imaging guided. So apposition is like no any malapposition in the post stenting or post balloon dilatation of the stent over the entire length more than 0.4 mm with longitudinal extension more than 1 mm. What are the dissection of base? At least more than 60-degree angle at dissection side, more than 3 mm length of flap is there, and 5 mm between the edge of this lesion stenting, and they are post dilatation of the stent or additional stent implantation is recommended if necessary. So 5,586 patients.
એન્જિયોગ્રાફિકલી તમે સ્ટેન્ટ મૂકો તો આવું માલ પોઝિશન ને આવું બધું થવાના રિસ્ક કેટલા પરસન્ટ હોય આઉટ ઓફ 100?
If exactly I don't know.
Less than 1%, less than 10%. સ્ટેન્ટ થ્રોમ્બોસિસ પતા હોય છે. સ્ટેન્ટ થ્રોમ્બોસિસનો રેશિયો કેટલો કે જેને આઈઓએસ ગાઈડેડ નથી કરેલો એમાં?
It depends on
અપ્રોક્સિમેટ મને નથી ખબર, હું ખાલી જાણવા માંગુ. You are एक बेटा का था कि 5-15
means the define is the time limit. If there is acute stent within 24 hours to 48 hours, so within 48 hours હોય તો 1%, 1 to 2%. Within 48 hours.
within 1 year હોય તો
1 month. 1 year માં સર પછી ISR માં જતો રહે, instant rate stenosis માં જતો રહે. But yes, at 1 month we can say means 2 to 2.5, around
આઉટ ઓફ 100 બે જણને એવું થઈ શકે.
2. Yes.
ઓકે, જો આપણે આવ્યા
ઇવન વિથ DES એટલે અત્યારે જે કહું છું
Sorry?
ડ્રગ એલ્યુટિંગ સાઇડ.
Yes. Actually, it is not related to the stand. They are primarily the main thing is the procedure complication and the
Technical
lesion
issue.
return.
વચ્ચે જગ્યા રહી ગઈ હોય, માલ પોઝિશન થઈ ગયું હોય,
Stand
એંગલ
full
રહી ગયો
expansion
હોય,
ના થયું હોય, proximal અથવા distal edge dissection થઈ ગયું હોય.
લેન્સ પ્રોપર ના હોય.
અને ઘણા બધા કેસની અંદર તો સર એન્ટીપ્લેટેડ લેવાની બંધ કરી નાખ્યો હોય.
હા, એ તો છે જ.
The majority, if the post-static dilatation is not adequate, because angiographically we cannot 100% accurate how much the pressure will be. So 5,586 patients from different center, different 20 sites, they assess for the eligibility as per the inclusion criteria. And Wonderment randomization from May 2018 to 21, 1,639 only out of these patients. Rest of are not included because of this reason. Why? Because there are showing some patient having guided case for CME, some having patient deferred for revascularization, some unable as per the clinical situation, some having cardiogenic shock, and some now refuse consent. So they divide angiographically 547 and 1019 intravascular imaging, and as you said, these patients who withdrawn consent and rest of violation of protocol, because if we are subgrouping this angiography guided and intravascular image guided, somehow 12 patients or more than that involved in this like 30 protocol violation imaging device used in this angiographically, and 40 patients who didn't involve because the balloon of hygroscopy doesn't cross the lesion, so they were excluded. So lost one follow and zero lost in angiographically. They follow this patient on OPD basis or telephonically after the 1 year, and they define 1,019 including the analysis intention to treat if whether it is involved in study or not. So these are the patient having some baseline characteristic who involved in this study, like majority of mean age of this 65 year of age having involved in this study, and a majority of male patient 79.3% is male patient. And what are the presentation in this study? That like ischemic heart disease like 49, acute coronary syndrome, ST segment, non-ST, ACS having 50.9, and having all these include medical history, EM hypertension, dyslipidemia, history of smoking, renal insufficiency, and previous intervention, PCO, previous MI, and involved mainly on preserved EM in this category. So these are about the patient's baseline characteristic, and these are about the lesions characteristic.
So પાછળ ગયા તો એક્યુટ કોરોનરી સિન્ડ્રોમ વાળા બે જે પેશન્ટ હતા એમનું એવરેજ ઇજેક્શન ફ્રેક્શન 45% કરતાં વધારે હતું, 46-47. ટૂંકમાં
Within
એમાંય તો હતા ને પ્રભુ?
yes,
ઓકે, ઇન્ટરેસ્ટિંગ ને. અને સ્ટેબલ વાળાને જેને સબ્જેક્ટ કર્યા છે એને સે કયા ઇમેજિંગ સ્ટડી પછી વાયબિલિટી સ્ટડી કરી હતી, શું કરી એવું કંઈક લખ્યું હશે ને લોકોએ?
no, they doesn't.
ના, એટલે કર્યું લખ્યું તો હોય, આખો ડિટેલ વાત તો એમાં ક્યાંક મળે કે સ્ટેબલ વાળામાં આ વસ્તુ આવતી હોય તો લીધા હોય. કે બધા સ્ટેબલના નામથી આપણે સ્ટેટ મૂકવાના જ જવાના,
Yes, yes.
રાઈટ? એટલે એમાં સિલેક્શન કર્યું હશે. આ તો બહુ વન ઓફ ધ મોસ્ટ સેફેસ્ટ ટ્રાયલ છે, કંઈક કંઈ કર્યું જ નથી એવું.
That's why they
Ah,
define the
that's
superior
why-
trial.
હા, એટલે આ પેલો આઈવસનો પ્રણેતા બોસ્ટન છે અને પેલો તમારું આ ઓસીટીનો પ્રણેતા એબર્ટ છે, એટલે એ બે જણા ફંડ કરીને કાઢી મૂક્યા, જાઓ રમો છોકરા, એવી જ વાત થઈ.
એટલે એકદમ સેફ કહીએ ને એ
હા, રિયલ લાઈફ સિનારીઓ આના કરતાં કેટલો ડિફરન્ટ છે પ્રભુ.
ટાર્ગેટ પ્રૂવ કરવું હતું એટલા.
રિયલ લાઈફમાં એક્યુટ કોરોનરી આવ્યું હોય તમને અને તમારું 56% EF હોય તો આવો એમાં ભગવાન બધા ના આપે. હે
Yes.
પ્રભુ?
Krishna Kadari.
So having all this comorbidity with lesion, they are defined as bifurcation, CTO. So these are the percentage going through imaging guided versus angiographically guided. So what are the number of vessel involved, 1 vessel, 2 vessel or 3 vessel, and having intravascular imaging device used, the majority, this is mainly on the operator.
આ ગળે જ ના હોય તો 30% ને તો તમારો ટ્રિપલ વેસલ ડિઝીઝ છે અને તમારો એવરેજ રિજેક્શન કદાચ 50% હોય. હાઉ ઇટ ઇઝ પોસિબલ યાર? હે ટ્રિપલ વેસલ વાળાને એમાં આવે ફાટી પડે. સાચું કહું છું ખોટું કહું છું?
Maybe they are stable issue.
Rather, acute MI is one of the most complex procedure, primary PCI એ જ ઘણું છે.
Actually, sir, primary PCI માં છે ને, it is not in between complication. Either slow flow, no flow થાય અને પેશન્ટ BTB માં જાય અથવા પેશન્ટ એકદમ સ્ટેબલ હોય. એક્યુટ MI માં ખાલી બે વસ્તુ એક જ વસ્તુ થાય. બીજી બધી જે કોમ્પ્લિકેશન છે, ક્રોનિક કોમ્પ્લિકેશન છે એ એક્યુટ MI માં નથી થતી.
બરાબર છે, સાચી વાત છે. પણ આ તો એક રીતે ગળે 30% લોકોને તમારે ટ્રિપલ વેસલ ડિઝીઝ છે ઇમેજિંગ ગાઈડમાં. હા આ તો બરાબર સાવ આમ ચોટલીવાળા સમજાય એવી રીતે ડેટા આપેલા છે. આનું કોઈ રિવ્યુ કર્યું? આનું કોઈ
એટલે તું ના પાડે છે ને, પણ તમને ડાઉટ હશે, બે ડાયગોનલ હશે ને બે ડિસ્ટ્રીબ્યુશન હશે, એકની એવું બધું હશે ને.
ના સર, એને ટ્રિપલ વેસલ ડિસીઝ એ લોકો કહી ના શકે ને ક્રાઇટેરિયા પ્રમાણે.
એટલે આનો કોઈ કટાક્ષ કર્યો, કોઈ કોમેન્ટ્રી મૂકી આ ટ્રાયલ પર? કોઈ સારા વ્યવસ્થિત માણસ હોય તમે મૂકી શકો આને. ક્યાં એચએમઆર આવ્યું હતું કેમાં પબ્લિશ? એનઈજીએમાં પબ્લિશ થયું. આનો કટાક્ષ કરો, કન્સલ્ટન્ટ બે ત્રણ જણા રિવ્યુ મારીને લખો કે આ બધું શું ચાલ્યું. હા તો જ જવાબ દે, બાકી આખા ગામને રમાડ્યા કે સારું. સાહેબ આગળ પૂરું કરવું છે 9:30. કન્ક્લુઝન કહી દે ને, કન્ક્લુઝન કહી દે.
Okay, sir. The primary endpoint having this showing from the baseline day 0, they showing the imaging guided disease is 7.7% statistically significant. This difference angiographically guided, so they are showing the hazard ratio. P value is 0.0.
What is the absolute risk reduction here? Count કર્યું છે? This is relative risk reduction. Absolute risk reduction કર્યું?
Confidence interval 95.
This is relative risk reduction. Absolute કરને તો સમજાય કારણ કે આમાં નહીં હોય.
5%. So they are showing the 20 cases of one patient having benefit from IVOS-specific guided. So
એ જે 20 પેશન્ટ છે એ એક્યુટ કોરોનરી વાળા હતા કે સ્ટેબલ વાળા? એનું કાંઈ પોસ્ટ હોક એનાલિસિસ છે એ બી કરવું પડશે ને, કારણ કે એક્સેપ્ટ આપણે એક્યુટ વાળામાં તો કરતા નથી.
લિમિટેશન બતાવો ને,
લિમિટેશન
હા લિમિટેશન બતાવો.
So basically they are showing that for only 45%. If they are saying that if they involve more patient with intravascular imaging, then the result will be better than this. So if we only involve 45.5% patients. So because of the duration and follow-up.
આ વાક્યનો મીનિંગ શું? રિઝલ્ટ માઇટ બી મોર પોઝિટિવ if we could achieve result in more patient.
Actually,
પ્રાઇમરી પીસીઆઈ ને જ ઇન્ક્લુડ કર દો ને પછી કહો.
actually they are saying that means using OCT, OCT માં there is specific criteria કે stand observation આટલું હોવું જોઈએ, આટલું હોવું જોઈએ. That criteria was not met, means that was met in only 45%. So optimum result with OCT was not achieved.
ના સર એ રીઝન ના થવાનું કારણ છે ને, એ કારણ ઉપર કોમેન્ટ કરો ને કે હા 45 ની બદલે 90% માં અચીવ કર્યો તો અમારું રિઝલ્ટ વધારે સારું. ધેટ ઇઝ નોટ ધ પોઈન્ટ. પોઈન્ટ કે વાય ખાલી 45% માં થયું. ધેટ ઇઝ ધ પોઈન્ટ.
Sir, frankly speaking, આ બધા ટ્રાયલમાં છે ને એક વસ્તુ જે લોકો ઇન્ક્લુડ નથી કરતા, they should include the operator's experience.
હા એ તો છે જ. તો આપણે એવું માની લઈએ કે સારા 10 વર્ષ વાળા કાર્ડિયોલોજિસ્ટ છે તો કર્યું જ હશે બરોબર. તો ભાઈ અરે યાર આવો
So
નો કોમેન્ટ.
So Renovate complex PCI trial support the intravascular imaging guided PCI in the treatment of patients with complex lesion who are undergoing PCI. So having a benefit of we are using intravascular imaging. So in our scenario it is not possible.
એટલે એટલો કોમ્પ્લેક્સ શબ્દ વાપરીને છે ને
It is possible, but it is at the operator's discretion. Operator ને જરૂર પડે ત્યાં આગળ યુઝ કરવું is beneficial. જેમ કે means
નયા પેટન્ટ ને દેશો ચીજ પુરાની નામ કોમ્પ્લેક્સ આપ્યું બાકી અંદર તો કશું કોમ્પ્લેક્સ હતું નહીં અને છતાંય આપણને ડિઝાયર્ડ રિઝલ્ટ મળ્યું નથી. કંઈ એબ્સોલ્યુટ રિસ્ક રિડક્શન નથી. તમારું પેશન્ટ સિલેક્શન બધા હાલતા ચાલતા આવીને એન્જિયોગ્રાફી માટે સુઈ ગયા એવા પેશન્ટ લીધા હતા. કાર્ડિયોજેનિક્સ ઓફ ધ મોસ્ટ પ્રિવેલન્ટ છે કોમ્પ્લેક્સ પીસીઆઈ આ કોમ્પ્લેક્સ લિઝનમાં એને તો તમે આઈડિયા નથી કરવાનું. અને ઓપરેટર પ્રિસ્ક્રિપ્શન હવે 99% કાર્ડિયોલોજીસ્ટ જ્યારે કાર્ડિયોલોજી શોપમાં આવ્યો હશે ત્યારે નહીં કરે આવું
સ્ટેથોસ્કોપ ની ઇકોકાર્ડિયોગ્રાફી જોડે સંભાળવાનું છે સ્ટેથોસ્કોપ નું કોઈ એના કરતા ઇકોકાર્ડિયોગ્રાફી ની સંભાળો તો સારું સંભળાઈ જાય ફેસિલિટી ડિપેન્ડન્ટ
ના પડે પેલું આ બધું ના કરે
Contrast, average contrast they have used is means in IVUS they have used around 200 ml average contrast, average as per this study, and in OCT they have average contrast is 260. So 200 and 260 जो cardiogenic shock માં ઉપર થાય તો પછી ખાલી ડિક્લેર
ડાયાલિસિસ મશીન સાથે જ રાખી હશે ને પુનિતને કીધું લેજો તો ડીએનસી લઈને ઉપર નાખી દે પહેલેથી
સરખું રિઝલ્ટ લેવા માટે પેશન્ટનું પોકેટ કેટલું હલકું થયું બેમાંથી એ જોવાનું તો જોવાનું જ નહીં
એક્સોડ હશે ને કયા દેશના હતા કોરિયા આવી કોરિયા છે
પેશન્ટનું પોકેટ
આ કઈ કેવા એનીજીએમ માં એનીજીએમ ના ઉઘડા દેવાય